I'd like to acknowledge the traditional custodians of the land on which I'm recording today and pay my respects to elders past and present. I'm Kate. I'm an Australian pharmacist with more than 25 years of experience working across hospital pharmacy, community pharmacy, palliative care, aged care, and now voluntary assisted dying. Welcome to Pop Pod, the clinician edition of Prescribe or Pass. Look for me on Instagram, TikTok, Facebook, and YouTube at Prescribe or Pass. Every episode explores one medicine, one condition, or one clinical concept, explaining not just what we do, but why we do it. Whether you're a pharmacy student, pharmacist, or any clinician who works with medicines, welcome to the Pop Pod. This is episode 5 in our ADHD medicines series. If you've been following along from the beginning, thanks for joining me. I hope you're finding it interesting and educative. If you're jumping in here, this episode will make sense on its own, but you'll get the most out of the series by listening from the start. So far, we've covered quite a bit of ground. In episode 1, we explored what ADHD is, why it isn't simply about being distracted or hyperactive, and why the old idea of ADHD being caused by a dopamine deficiency is an oversimplification. In episode 2, we looked at why one person might be prescribed Ritalin whilst another receives Vyvanse, and why medication choice is based on many factors, not simply which medicine is strongest. In episode 3, we focused on methylphenidate itself, how it works, expected benefits, common adverse effects, and key counselling points. Then in episode 4, we compared the different methylphenidate formulations, including immediate release Ritalin, Ritalin LA, and Concerta, discussing how their release mechanisms influence onset, duration, and clinical use. In this episode, we're learning about the amphetamine family. By the end, you should be able to describe the relationship between dexamphetamine and lisdexamfetamine, explain what a prodrug is, understand why Vyvanse generally lasts longer than dexamphetamine, explain why some patients are prescribed both, discuss food interactions and the evidence behind common advice, separate evidence from myth regarding vitamin C, and provide practical counselling and monitoring advice for patients. Dexamphetamine and Vyvanse aren't completely different medicines. They're actually very closely related. Think of them almost like two different ways of delivering the same active drug. Dexamphetamine is exactly what the name suggests. It contains dexamphetamine. Vyvanse, however, contains lisdexamfetamine. Chemically, it's really dexamphetamine attached to another molecule called lysine, which is simply an amino acid. So although patients may think they're completely different drugs when moving from dexamphetamine to Vyvanse or adding dexamphetamine to Vyvanse, they're actually receiving the same active stimulant, just delivered in a different way. And that distinction becomes incredibly important. How do amphetamines work? We've already discussed that ADHD isn't simply caused by low dopamine. Instead, medicines alter signaling within particular brain networks involved in attention, executive function, and impulse control. Amphetamines work by increasing the availability of dopamine and noradrenaline in those pathways. Unlike methylphenidate, which mainly blocks reuptake of those neurotransmitters, amphetamines also encourage additional release from nerve terminals. That increased signaling can improve sustained attention, organization, impulse control, working memory, task completion. Again, they don't create attention where none existed. Rather, they improve the efficiency of those brain circuits. So what is a prodrug? This is probably the most important concept in this episode. A prodrug is a medicine that is administered in its inactive or much less active form. Your body then converts it into the active medicine. Many medicines are prodrugs. For example, codeine is converted into morphine, and valacyclovir becomes acyclovir. Lisdexamfetamine becomes dexamphetamine. The body performs that conversion after absorption. After lisdexamfetamine is absorbed, it circulates in the bloodstream largely unchanged. It does not sit in a special storage compartment. The molecules simply keep moving through the blood until they are taken up by red blood cells and converted into dexamphetamine. You can think of it like cars driving around a city with parking inspectors. Not every car is inspected at once. The cars keep circulating, and over time they encounter an inspector. In the same way, at any given moment, only some lisdexamfetamine molecules are being converted, while the rest continue circulating. That steady, ongoing conversion means active dexamphetamine appears in the bloodstream more gradually than it does after immediate release dexamphetamine. That conversion step slows the appearance of active drug in the circulation. This is fundamentally different from simply putting dexamphetamine into a slow-release capsule, as you can't really hack Vyvanse's release. With some modified tablets, crushing or chewing the tablet can destroy the delivery system and release the drug all at once. With Vyvanse, the capsule dissolves quickly. Even if you open the capsule and dissolve the powder in water, which is an approved administration method, you've not bypassed the rate-limiting step. The rate-limiting step is the enzymatic conversion inside red blood cells, not the capsule or the stomach. Why does Vyvanse last longer? Well, as I just said, the capsule dissolves fairly quickly after swallowing. What's slow isn't the capsule. What's slow is the body's conversion of lisdexamfetamine into dexamphetamine. Another way to think about it, imagine dexamphetamine is money. Taking dexamphetamine tablets is like being handed cash immediately. Taking Vyvanse is like being handed a gift card. You have the value immediately, but you can't spend it until it has been converted into cash. That conversion creates a smoother rise in blood concentrations. Many patients describe this as they don't feel it kick in, or it feels smoother. Of course, individual experiences vary enormously. Some people still notice a definite onset, others still experience a noticeable wearing off later in the day. But compared with immediate release dexamphetamine, Vyvanse often produces a more gradual effect. Does Vyvanse always last all day? No, this is another common misunderstanding. Product information suggests around 10 to 13 hours, but real-world duration varies considerably. Some patients obtain 8 hours, others 12, occasionally even longer. Why? People absorb medicines differently, they metabolize medicines differently, and their daily demands differ. Someone working a 14-hour shift may feel the medicine doesn't last long enough. Someone studying for 4 hours might feel it lasts perfectly. So, how long does Vyvanse last? Doesn't really have one universal answer. Why do some people take both Vyvanse and dexamphetamine? Patients are often surprised when they're prescribed both medicines, and at first glance it sounds odd. If Vyvanse becomes dexamphetamine, why prescribe dexamphetamine as well? And there are several reasons. One is morning onset. Vyvanse takes time to be converted. Some patients need symptom control earlier than Vyvanse alone provides. A small dose of immediate release dexamphetamine may work whilst Vyvanse is gradually converting. Another reason is afternoon coverage. If Vyvanse provides most of the working day but wears off before evening commitments, a clinician may prescribe a small dexamphetamine booster later in the day. And this can help patients complete study, parenting responsibilities, or evening work. Not everyone needs this. Many patients achieve excellent control with Vyvanse alone. Others prefer dexamphetamine alone because they like being able to tailor timing more precisely. Again, this comes back to something we've discussed repeatedly throughout this series. ADHD treatment is individualized. Food and Vyvanse. Patients often ask, should I take it with food? And the answer is that Vyvanse can be taken with or without food. A high-fat meal may delay how quickly peak concentrations occur, but it doesn't substantially reduce the overall amount absorbed. Clinically, many patients like to take it with breakfast because that fits their routine. Some also find eating breakfast at the same time means they're able to get in a substantial meal before the drug reduces appetite suppression later in the morning. Protein has become a popular topic online. You'll hear claims that protein somehow activates Vyvanse. That's not correct. The conversion of lisdexamfetamine occurs through enzymes in red blood cells. It doesn't require eating protein. Having said that, adequate protein at breakfast may still be helpful for completely different reasons. A nutritious breakfast improves satiety, helps maintain energy, and reduces the likelihood of forgetting to eat later in the day. Those are practical lifestyle benefits, not activation of the medicine. Vitamin C myths. This topic creates enormous confusion online. So let's separate fact from fiction. You'll often hear people say, never have orange juice with Vyvanse, or vitamin C completely stops ADHD medications working, and neither statement is accurate. Acidic urine has been shown to increase the elimination of amphetamines from the body. If the urine becomes more acidic, amphetamines are excreted more rapidly by the kidneys. Conversely, alkaline urine slows excretion. That pharmacology is well established, but that doesn't mean drinking one glass of orange juice suddenly switches off your medication. For most people, eating a normal diet, including a normal vitamin C intake, has very little clinically significant effects. Large doses of vitamin C supplements taken very close to medication may theoretically have a greater impact, but the evidence for meaningful effects during every day is limited. Importantly, because Vyvanse is absorbed as lisdexamfetamine before conversion, stomach acidity is not the issue people often imagine. The practical message is simple. Patients do not need to fear fruit. They do not need to avoid healthy foods. If someone is taking a very large dose of vitamin C supplements, it's reasonable to discuss timing with their prescriber. And it would also be a good opportunity to ask them why they are taking large doses of vitamin C supplements. But normal dietary intake is not something most patients need to worry about. Common adverse effects. Many effects overlap with methylphenidate because they are stimulant related, and these include reduced appetite, dry mouth, insomnia, increased heart rate, increased blood pressure, anxiety, irritability, headache. Those often improve after the first few weeks, but not always. Patients should know what to expect whilst also understanding when to seek medical review. Some counselling points. When supplying dexamphetamine or Vyvanse, pharmacists play an important role. Some practical counselling points include take the medicine early in the day where possible. Avoid taking afternoon doses too late unless specifically directed. Expect appetite suppression. Rather than waiting until lunchtime to eat when appetite has disappeared, many patients benefit from eating a substantial breakfast before the medication reaches full effect. Hydration is important. Dry mouth is common. Sleep should be monitored. Difficulty falling asleep may reflect dose timing, dose size, or another contributing factor entirely. Patients should avoid sharing medication. These medicines are Schedule 8 controlled drugs. They are prescribed specifically for the individual patient. Storage should also be discussed, particularly around children or visitors. Misappropriation is illegal. Monitoring. Monitoring extends beyond simply asking, is it working? Clinicians should regularly assess symptom improvement, blood pressure, heart rate, weight, appetite, sleep, mood, and adverse effects. Children also require monitoring of growth over time. The aim isn't merely symptom control, it's achieving symptom control while maintaining overall health and quality of life. Sometimes a medicine works beautifully for attention but creates unacceptable insomnia. Sometimes appetite suppression becomes problematic. Sometimes another formulation provides a better balance. Finding the right regimen often involves careful follow-up and ongoing adjustment, rather than a single prescription that never changes. Key take-home messages. Dexamphetamine and Vyvanse belong to the amphetamine family. Vyvanse contains lisdexamfetamine, which is converted within the body into dexamphetamine. Because that conversion takes time, Vyvanse generally produces a smoother onset and longer duration of action than the equivalent dose taken as dexamphetamine tablets throughout the day. Some patients are prescribed both Vyvanse and dexamphetamine because immediate-release dexamphetamine can provide earlier onset or extended symptom control later in the day. Food doesn't activate Vyvanse, although maintaining good nutrition remains important. Vitamin C myths are often exaggerated. Normal dietary vitamin C is not something most patients need to fear. And finally, successful ADHD treatment isn't simply about choosing the right medicine. It's about choosing the right medicine, the right formulation, the right dose, and the right monitoring plan for that individual person. If you are listening to this podcast as part of your continuing professional development, here are a few questions to reflect on. How would you explain the concept of a prodrug to a patient using simple, everyday language? If a patient asked why they take both Vyvanse and dexamphetamine, how would you explain the rationale? Have you previously repeated any common advice about vitamin C and ADHD medicines? After this episode, would you modify how you counsel patients? Beyond asking whether the medicine is working, what aspects of monitoring should pharmacists routinely assess during follow-up? You may also wish to record how today's learning might influence your future counseling or clinical practice. Over the last 5 episodes, we've explored the stimulant medicines used to treat ADHD, from understanding the condition itself through methylphenidate, dexamphetamine, and Vyvanse. But stimulants aren't the right choice for everyone. Some people don't respond well to them. Some experience unacceptable side effects. Others have medical reasons why stimulants may not be appropriate. So in episode 6, we will turn our attention to the non-stimulant ADHD medicines. We will discuss atomoxetine, guanfacine, and clonidine, how they work, who they're most appropriate for, when they might be used alongside stimulant medicines, what patients can realistically expect when starting them, and the key counselling and monitoring points for clinicians. I'll see you then.